Project Echo Dementia for January 24th on this glorious sunny day here in Washington. If you're new to us, we are so glad that you're here today and we'd love to meet you. So please do enter your name and where you're from in the chat. We're very fortunate to have our own hub team member, Dr. Mimi Pattison, presenting with us today on feeding in the setting of advanced dementia. We then also have a case presentation with Dr. Amore, and there will be plenty of time for discussion. So I saw somebody, please rename, if you can, yourself with your first name and your last name and your clinic, so we know who you are. And please mute yourself if you're not speaking and turn your camera on if you can. And if there's more than one person in the room, then please enter all of the names in the chat. Thank you. For all University of Washington faculty, staff, or students, many of you have already completed that mobile text registration to sign in, but if you've not, you want to send your University of Washington or UW email address to the number you see here. And then you'll receive a response stating that your number has been updated. And if you don't receive that message, you could sign in at uwcme.org. After the registration, you text this 10085 to that number, and you should receive a response stating thank you. We've recorded your attendance to this echo. For all other attendees, your attendance is recorded by Sammy and through Zoom Analytics. So that's why another reason why we need you to display your full name. And Sammy can reach out in the chat if she needs additional information. There are so many wonderful programs through ECHO. There's an ECHO Geriatrics, which meets on alternate Fridays, or actually the third Friday of the month. There's a UW Traumatic Brain Injury Behavioral Health ECHO, which is on the first and the third Fridays of each month. There's a Psychiatry and Addictions ECHO on Thursdays. There's a telehealth health training series that meets on the third Friday from 11 to 12. There's also a really helpful telephone consultation number for complex pain medication regimens. If you have questions, you can call this number, and really helpful for deprescribing and managing pain and opioids. There's also a CME accredited case conference, the UW Telepain series, which meets from 12 to 1:30 on Wednesdays. Additionally, there's grand rounds, neurology and psychiatry grand rounds, which you can participate in via Zoom, and there's also, they're archived, so you can watch asynchronously. Very soon on March 7th, mark your calendars, Friday, March 7th is the first, I say first, Dementia Innovation Summit with primary care at the forefront. And really, we know, and of course, in our ECHO, this is experienced that, primary care providers, you all play a really crucial role in timely detection and management and support of people who are living with dementia, with cognitive health challenges. And this day is really focusing on deepening your knowledge, developing skills, and also networking and connecting with other like-minded clinicians and providers. And as you see, you can earn 6.25 CMEs. Please do register. You see the QR code here, and you see the key topics: evaluation of cognition in primary care, brain health and practice, dementia is a team sport, 3Ds, depression, delirium, and dementia, and goals of care, advanced care planning. And we're very excited about this. This is made possible through many people working hard together, and in particular through the Dementia Action Collaborative. Please do try to join that if you can. And then please bring your cases forward. We are all learning together. And so bring the case forward, reach out to Sammy. She can help also with kind of populating this case presentation. We can all help you. And, you leave with recommendations for that person who's living with dementia and their family. And we are here as a resource for you and to support you, and we all learn together. So please bring your cases forward. No case, as we've said, before, is too simple. Previously presented cases are welcome. We love updates. It helps us to see people over time and understand better, how people can change and how they respond to the recommendations. We never include PHI in our presentations, so don't ever display anything, of course, that would reveal any personal health information. These sessions are recorded and available on our website, and then there's a 1-minute post session survey, which, your feedback is so invaluable to help us to improve this over time. We've already talked about the accreditations. We don't have any disclosures today. The speaker doesn't have any financial relationships with any companies. There's nothing to disclose. And if there ever were, all of these financial relationships are mitigated, but in this case, there are none to disclose. Here's our hub team smiling. As you see on the top banner, this really spans a broad number of health systems and the Dementia Action Collaborative. And furthermore, as you see, in the state of Washington, we provided over 1,700 instructional hours since June 2020. And in 2023, 100% of respondents reported that Project Echo Dementia improved their quality of care for patients with dementia, and nearly 64 reported changes by others within their organization based on this participation. So that information, that knowledge, that care is really spreading locally. You see, we have 96 sites serving 250 zip codes, over 243 providers, and it's your participation and your sharing of the value that helps us to grow. So please do share with your colleagues if you think this would be beneficial to them as well. We do actually, in this case, have one today. Thank you. And without further ado, as I said, we're super fortunate to have our very own Mimi Pattison, hub team member and palliative medicine physician. And she will speak to us today about feeding in the setting of advanced dementia. Thank you so much, Mimi. And I'll stop my share.
Okay, and I'm gonna go ahead and share and get set up here. One more thing, okay, all right. So Nancy, thank you. And thank you so much for this opportunity. Can I digress a little bit and start with a story? Things happen for usually a good reason. And honestly, just 2 mornings ago, I was going for a walk with 2 friends. And as my friend was getting her dog kind of ready to go, she started talking about her mother-in-law who has dementia and is having some changes. And her mother-in-law is in Florida. And my friend actually said about 3 things that sent me into orbit, but only one of them I'm going to share with you today. And she talked about how she was getting more confused and having some hallucinations and things. And then she said to me, and then the nurse called me and said, your mom's not eating. Should you want me to get a feeding tube put in her? And I thought, oh no. So this really is happening. But of course, that was in Florida. Hopefully that's not happening as much with some of the education that we're doing here in the state of Washington. But just to start the presentation with that story, certainly the issues and the challenges are alive and well out there. So this is going to be a case-based approach and a very practical approach, a very clinical approach. And we're actually going to have a clinical conversation after I go through some basic didactic material. And our patient is Mr. B and his daughter Paula. And I just pause and honor their story and all that they have taught us and what we're here to share with you today that we learned from them. I'm going to be doing the presentation. I have some supporting act with me today, Dr. Kofer, one of my colleagues, and Dr. Amor from the Swedish Geriatric Fellowship are going to be helping out later, and you will meet them. So this presentation is entitled Feeding in the Setting of Advanced Dementia. And as I was reflecting on it, I thought, oh my gosh, I just wonder if a better title wouldn't be Communication with Families and Caregivers in the setting of advanced dementia. Those situations can be so very challenging. We've been in this work for a long time. We've had a lot of experience. And often learn from the school of experience, which isn't the most fun way to do it. So we're here to share our experiences with you today. So I want to start with our learning objectives. And at the end of the session, you will be able to identify the questions and concerns that families have around the use of artificial nutrition and hydration in persons with advanced dementia. And then what are the clinicians' concerns in the same setting? And the lists are really very different. And then to be able to formulate 2 medical recommendations that match the family preferences for the case that's presented. And then to be able to recognize and respond to emotional cues in conversations like we're going to see today about very high consequence decisions. And I would like to start with a reflection from this phenomenal woman, Maya Angelou. And many of you, I'm sure, have heard these words. I've learned that people will forget what you said. People will forget what you did. People will never forget how you made them feel. And when we're talking about advanced dementia alone, much less now having feeding difficulties, we know what a highly emotional issue that is. And therein lies the big challenge in having these conversations. So what Maya gives us guidance and wisdom on is so applicable here. And we know that in communication, we always want to make sure that our patients or families feel like we're hearing them. We also want to make them feel felt. So feeling felt is a big part of these conversations. So let me introduce you to Mr. B. Mr. B is an 89-year-old gentleman with advanced dementia. He has a history of hypertension and high cholesterol. He was hospitalized 3 weeks ago and treated for a urinary tract infection. And during that hospitalization, he actually developed a stage 1 sacral ulcer. He went back to his long-term care facility, and since then, he's been sleeping more, communicating less, coughing on thin liquids, and he developed fever and respiratory distress. So he was readmitted to the hospital and is now being treated for aspiration pneumonia. And you as a clinician need to go in, or you're going to assume his care, so you need to talk about his ongoing care. His daughter, Paula, is at the bedside by herself. And that's the setting that we're going to launch into in a little bit. So first of all, the big picture considerations. And I do hope that this session can be somewhat interactive. And what is happening to Mr. B? If you have a thought about that, unmute and speak up, or feel free to put something in the chat. What's the big picture here in this case that I just described? What's happening to Mr. B? We know he's got pneumonia, but he's already been hospitalized a couple times, and there's a lot of other things going on. Any thoughts? Okay, so Mr. B has advanced dementia. The next question, we like the surprise question when we think about going in and coming up with a care plan really for Mr. B. Would you be surprised if he were to die in the next 6 months? Given what I just told you, would any of you be surprised if Mr. B were to die in the next 6 months? As you, Brock, I see you shaking your head. I see a number of heads shaking no. You wouldn't be surprised. You wouldn't be surprised. You guys, you know what? That's a great screening question to ask yourself as you come up on a situation like this or admit anyone with serious chronic illness to the hospital. So, you know, I said 6 months. I think the reality is that he is at risk for dying within weeks to months. And I'd like you to pay attention to the term that I used, risk for dying. We're going to go in and we're going to talk to Paula. We have no idea what she knows about this. And so this is probably some serious news that we're going to have to share with her. Now, we don't want to do that in any threatening manner or promise. So we talk about risk for dying because that's what we do know. We do know people's risk for dying. So a great screening question to ask in these kind of situations. So what is Paula likely to be feeling at this time? She's sitting in the room all by herself with her dad. He's not responding to her. He probably has an IV going with IV antibiotics and, you know, what's going on here? Is this conversation likely to be high intensity or low intensity emotionally? Any thoughts about that? Is this going to be a 5-minute conversation, slam dunk? Kyle says high intensity. You are right. And what's the high intensity aspect of this? Any thoughts about that? Well, I'm going to tell you it's going to be the emotions involved in that. And that's what we have learned time over time and how important it is to deal with the emotions. When you think of the cognitive piece about this, yeah, clearly Mr. B has advanced dementia. Now he can't eat. So Barack says grief, all kinds of things might be going on. High intensity and entering a new territory emotionally and medically. Difficult to accept that this is it. Thank you, Karen. Thank you. So we don't know what's going on with Paula. We have to discover that. And then Hillary says, understanding the goals of care. What are her goals of care? What are our goals of care? And how can we align that? So we know that this is going to be a high intensity and high emotional conversation with the potential for a lot of emotions, including shame. And really, that's the most challenging part of this whole conversation. As I said, the cognitive piece, where what we understand about where he is on the trajectory of dementia is pretty straightforward. And it's pretty straightforward in the literature when we look at specifically the feeding problem about how the best way to address that is. So one of our tools or tips that we teach in our communication class is being able to respond to emotional and cognitive cues. We always say, follow the patient cues. They will tell you where they want to take the conversation, what is important to them. Well, in this case, it's not the patient, and that adds a layer of complexity. So we talk about emotional and cognitive cues. Is this something familiar to folks? How it's important that we follow those? So what's an emotional cue? It's a statement that is tied to an emotion, and it may not be obvious. And you're going to have to use your curiosity, which is one of the most important clinical skills that you can bring into these situations, and figure that out. A cognitive cue is a little more straightforward, and it's a statement, although it may be masked in some way, that is actually requesting more information. So as you're listening to what your patient and or family, whoever you're talking to, are saying, you need to be in your mind making an assessment. You know, how do I need to respond to this? Is this emotional or is this cognitive? So let's just practice a little bit before we get started, okay? So there must be something you can do. Do you think that's an emotional or a cognitive cue? You can just put your answer in the chat. Yeah, there must be something you can do. How would we want to respond to that? Sylvia says emotional, emotional, feels like both, can be both. Okay. And if indeed you think it can be both, our strong recommendation is to always respond to the emotion first. Always respond to the emotion first. And you might, so you're going to respond with an empathic statement saying something like, you know, I wish I could make this into good news. There's a whole variety of responses. I'm not telling you this is how you need to respond. So let's try another one. I want a second opinion. Is that emotional or cognitive? Thoughts about that? I'm not seeing anything in the chat. You guys are thinking. There. If said in anger or frustration, emotional, but then discussion, it could be cognitive. Yeah. Yes. We recommend for this, and this is not uncommon, right? I want another opinion. I want to go to Swedish. I want to go to the U. Yeah. I want a second opinion. We recommend taking that as an emotional cue and responding that way. You know, I just really can't imagine how difficult this must be. And if that was a cognitive cue and the patient really wants that second opinion, they'll say, no, no, no. I want to go to Swedish. Can you get that arranged for me? They'll tell you, and they won't be upset if you responded to the emotion. They won't be upset. So always err on the side of responding to emotion. Oh, this is a favorite one, huh? We're hoping for a miracle. We're hoping for a miracle. Kyle says emotional, emotional, emotional. Brock's hoping for a miracle too. Good work, Brock. And as Sylvia says, that already shows some understanding of the severity. Absolutely. When do people call on miracles and on their faith? When do typically, I mean, a lot of people do it all the time. It's just, it's a part of them. But even those who do that all the time try to call up some, maybe some special powers at a time when they're sad, distressed, or they know that this is not what they wanted. So again, we highly recommend respond to the emotion. And Brock, I love it. That would be awesome. If that happens, we will celebrate that miracle with you. And now you've got to connect your thought to it and don't put a but in there. And is really the operative word in this sentence. And is it okay if we talk about how we're going to care for mom or dad, or if what we're hoping for doesn't happen? So that's aligning hope and intention. We as adults know that we can balance a couple of thoughts in our mind, but here I go. But I'm just going to tell you not to use the word but, and I just used it. And don't use the word but. Don't slap away what they said. Connect those thoughts with an and, not a but. So no butt slaps is a tip on communication. And, you know, when you're dealing with miracles, if I can just add, it really is so crucial to leave those spiritual sources of strength and hope intact. They are really important to that person, and you are likely to get fired or something worse if you try to destroy that. So say, you know, that'd be great. That would be awesome. We will really celebrate, you know, if that happens. I bet you could all tell me stories about this, right? and how you've responded and how maybe you didn't know what to say the first time that came up. Okay. So when we think of Mr. B, there's a lot of things going on. He has advanced dementia. What does the family know about that? But when we think about his ongoing care relative to feeding, what do we have in our toolbox today? What are all the options that we can consider? What are the possible options we can consider for Mr. B who is having trouble swallowing? Coughing on thin liquids, now he's aspirating, he has an aspiration pneumonia. What are all the things in our toolbox today? I've already mentioned one of them today, as I told you my traumatic story of my walk on Wednesday morning, hearing this. Hillary says referral to a speech and language pathologist, right? That could be something that we consider. I'm thinking more specifically, how are we going to provide him with some nutrition or hydration if indeed we think that's the right thing to do? Offer foods for pleasure, says Sylvia. Try to avoid very hard foods that he can't tolerate. Okay. Okay, so you guys are thinking. So one of the options that is out there and often gets brought up and often even before we get in and talk to the patient is some kind of artificial feeding via a peg tube. We know from the literature, and it's going on close to 20 years now that it's been in the literature, that this does not positively impact weight gain, real body weight gain, nor pressure ulcers. And Mr. B already has a pressure ulcer. Anybody want to venture a guess why he developed that pressure ulcer during his first hospitalization? It's probably related because he probably had an IV immobilization. Sylvia, right? He likely had restraints. You know, he could have not wanted that IV with those antibiotics, and he was immobilized. He's not, moving as much as he used to, but he likely could have been in restraints. And we know that trying to artificially feed these people does not impact any of those things. We could consider a time-limited trial of a tube feeding via Dopphoff or Keo feed and have specific goals. Sometimes we have to go there when the family just can't do anything different. And then obviously comfort feedings, or Sylvia had another name for it, I think. Comfort feedings, one-to-one hand feedings, scheduled feedings, for example, every 4 hours while people are awake, along with managing the symptoms that they may have. And if you wouldn't be surprised if Mr. B dies in the next 6 months, my hope is that he'll be referred to hospice. That would be good care for him. His body is ready for hospice. The question is that something he would want? And what does Paula think about that? And that we allow Mr. B to die naturally. What about TPN? Families are going to ask about that. They're not going to maybe use the word TPN, but they're going to say, why can't we just feed him in the vein? Yeah. And the answer is no. We all know that TPN is meant as a short-term intervention to foster recovery after a surgery or chemo or radiation. So in looking at the literature, I told you there has been literature published on this for close to 20 years. But back in 2013, the American Academy of Hospice and Palliative Medicine published their recommendation, and they revised it a few years ago. And again, they just reiterate the studies have found that feeding tubes do not result in improved survival, prevention from aspiration, or improved healing of pressure ulcers. In fact, it's been associated with more pressure ulcer development, often the use of restraints, distress about the tube. So assistance with oral feeding is an evidence-based approach that provides some nutrition and feeding problems. And in this final stage of the disease, assisted feeding may focus on comfort and the human interaction. We're going to talk a little bit about that rather than nutritional goals. Choosing Wisely has this as a recommendation. And back in 2014, the American Geriatric Society published their position statement in the journal with the same recommendation. So lots of support in the literature. As I said, the cognitive piece of how to care for Mr. B around this is really honestly pretty straightforward. So when we think about what might the family be worried about here? So let's talk about the family's concerns. We're preparing ourselves to go in and have a conversation with Paula. What do you think she's going to be worried about? What's one of the most common things we hear about? What's coming up for her as she hears or sees that her dad can no longer eat?
Pain.
Pain? Absolutely. Anything else? We can't let him starve, Carrie. How many hundreds of times have you heard that? Probably the most common response. Won't he be hungry? Exactly, exactly. So the family's concerns typically are very similar around starving to death, pain and dehydration, and then how can he get strong? How can he get better? You know, yeah, Carrie, if we don't feed him, how is he going to get better? So let's go to our side of the coin here. What are we worried about as we think about all those options that we talked about? I wonder if Paula already has in her mind that she knows she has to put a feeding tube in her dad because he can't eat. And somebody has recommended that to her, or at least brought it up. What are we worried about? Well, it's really kind of a different list, but we know that people who receive artificial feeding or fluids or IVs, that does not prevent aspiration. We know that. And in fact, as they're well hydrated and have more secretions, they may actually aspirate more, make it into a situation of fluid overload, the need for restraints, and then infection, bleeding, pulling it out, agitation, could really turn into a vicious cycle. So we have probably very different concerns than Paula does, because we know all about this, right? We understand, right? We do. I want to pivot a little bit here and talk about this is an article that was actually published just before COVID. Clinicians' views on empathy can be a barrier. And in situations like this, where we're talking about advanced dementia, it's something we deal with all the time. It's very common to us, and feeding, and we think, we understand all this, we get it. And we want to say that, oh, I understand all of this. Well, this group in Indiana did a study, and of all the clinicians they interviewed, 100% of the clinicians self-reported that they use an empathic statement when engaging with patients. And that's great, because that's what patients want to hear. And about 50% of these clinicians said that when they use the word, or when they say the phrase, I understand, that's an empathic statement. Well, more than 75% of the patients from this study and some previous studies perceive when the clinician says, I understand, they perceive that as dismissive and disrespectful. Although you might be inclined to say, oh, I understand how hard this is. I understand this. I understand this. You do not, because you don't know exactly the history and all the emotions that are being brought up by what's happening. And we often use it as a vehicle to get the conversation moving forward. We're busy, we have a limited amount of time. So instead of saying, I understand, what about something like, I can only imagine, or I can't imagine how hard this is for you. And then followed by a pause to give them time to kind of think about that and be able to move forward. Any questions about that? I thought this was a really enlightening study. We think we understand, you guys, we don't. Not unless you've been there. And you haven't been in their shoes. You haven't been in Paula's shoes. So I want to pivot one more time before we get into the conversation with Paula. Why do we eat? Why do you eat? Why are you guys eating lunch? You people off camera, and Sam was eating her saltines as we got ready for this. Put an answer or two in the chat. Why do you eat? I know we're talking about feeding tubes. Let's see. Leisure, we feel hungry. Nutrition, pleasure and sustenance, to be social, human contact. I love food, community, habit, sometimes emotional. Thank you. Those are all the reasons why we eat, aren't they? And you know what? It's important to consider that as we think about how are we going to supply, artificial feeding to someone with advanced dementia. So we eat because of taste, smell, texture, social connection, nutrition, emotion. Really, food is love. And our ability to show love for someone. Oh, Kyle, you had a celebration. Absolutely. Don't we all have family celebrations? What would it be like if somebody said, we're not going to have food this year. We're just going to get together and celebrate us and celebrate somebody's birthday, Are you going to go to that party? Maybe not. Anyway, food is love. And here we have, now we can no longer express our love for this person by providing them food. And that is a highly value-laden, emotional, and highly consequential situation. So of all the possible options for Mr. B, which is the best match for the reasons that most of us eat? Artificial feeding and B also, or comfort feedings. So just put in the chat A, B, or C. What's the best match for all of the things that are a part of feeding? C, 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 C. Very good, very good. You guys know this. You know it. The other thing I wanted to mention, I'm going to go back a minute. What happens as people develop progressive dementia? What happens to their oral intake? This is really important. And I think I told you in the story, Mr. B, was eating less, communicating less, sleeping more. They're less interactive and they have less intake. And, I learned this from a colleague, we use the term body wisdom. Kind of the body knows what it can handle and what it can't. And so appetite changes, interest in food, all of that changes. And we call that really body wisdom. And I love that phrase, and families seem to really understand that. So all of you seem very familiar with this situation and having these conversations. And we're actually going to go in and have a conversation with Paula today. And Dr. Lucia Amor, I don't think I can't even see her. There you are. Thank you. Thank you so much for being willing to participate in this today. And Dr. Amor has her way of approaching situations like this. And I've introduced her to our house model and have asked her if she'd be willing to give it a try today. And this is the template, the model, the visual model that we use in teaching communication and having a goals of care conversation, really at any type of conversation. And it's actually going in and building the house with the patient or family. And as we build that house, we build it in, we teach it in a linear fashion. We know these conversations often include some dancing and going back and forth, and we never want to do any wrestling. But as we start with the foundation, and we're going to go in and develop a relationship, and we're going to ask permission. Is this a good time to talk? Are you comfortable? We've reviewed the chart. We know what's going on. And then we kind of have to negotiate the agenda. Then the first wall of the house, and it's so important, we go into the patient's story. And there's 3 areas here that we really encourage you. And these are time efficient explorations. What have you heard about your medical condition? Another word we like to avoid using is, what do you understand? We don't like to say, I understand, but what have you heard? When we ask a patient or family what they understand, it often feels like a test to them. Our preference is to say, what have you heard about your condition? What have your other doctors told you? And then we want to find out where their strength and support is and how their illness is affecting their life. They'll tell us what their prognosis is, and in this situation, in terms of life expectancy and many other circumstances. So this is the patient story, and it's so important that we get this first. Then we ask permission to move to the medical story. If we identify a knowledge gap, this is when we give that medical information. We call that the medical story. And we deliver that as a headline, 15 words or less. We know it's going to generate some emotion, so we follow a headline by silence, and then we acknowledge the emotion. Then as we think about making a plan and recommendations to Paula, we do believe it is your professional responsibility to make a recommendation, not to ask the question that I heard was asked of my friend, do you want do you want this done to your mother? But a medical recommendation that is balanced, and that balanced medical recommendation is balanced on the patient story and the medical story. Summarize what you've heard, what's important to the patient, and then make a medical recommendation. And then finally, if they agree with your recommendation, which doesn't happen all the time, we have to do more kind of dancing with collaborative decision making. But either way, there's some collaboration then that moves us forward and kind of defines the details of the plan. So this is our house model that I've asked Dr. Moore to use today, and she's agreed to come in front of this audience and really make herself vulnerable. And she knows as much as you do about the case, and she knows there's a daughter, Paula, that she has to go talk to. And she does not know Paula's story. She does not know Mr. B's story. She does not know Paula's story. She chose to just go in and find that out herself. Just to clarify what all this other stuff is on this slide, on the back of our house card, we have a pocket card that clinicians can put in their pocket to use when they go in and have these conversations to kind of give them some cues about maybe what to ask. We have ways and words that work on the other side. So this is our house model of communication. So I want you all to be watching how Dr. Moore does this. And this is going to be a learning experience for Dr. Moore, and I've already talked to her about kind of how this is going to run. If she at all gets to a time where she just doesn't know what to say to Paula, she's going to time herself out, and she's going to ask you guys for help. And I'm probably going to time her out too, just to point out some things as she goes along, because she's given me permission for that. So we are actually going to offer her some help first. Will each of you please put a short question in the chat about, based on what I've said and what I recommend in getting the story, what's one question that you want to ask Paula, or that you would recommend that Dr. Moore asks Paula? Let's help get started here. Anybody have any thoughts? I know you do. Tell us about your dad, Carrie says. Yeah. Are you aware of any directives? You want to know about advanced directives? What's your biggest priority? Do you know his wishes? Have you ever talked to him about this? How much do you know about the condition? Oh, Lucia, those are a great start. Huh? Is that helpful?
Looks good.
Okay. So let's practice using the house model. And first of all, let me ask Paula to come into the room. Paula, thank you for joining us. Okay, I am going to stop sharing. And Dr. Moore, when you are ready, you go ahead and start your conversation with Paula.
Hi, Paula. My name's Lucia Amore. I'm one of the doctors from the palliative care team. We focus on giving care in line with what matters most to our patients and their family. Is now an okay time to talk with you about your dad?
Yeah, that would be good.
Yeah. Thank you so much for being here.
Mhm.
First, could you tell me a little bit about what you've heard about your dad's condition?
Uh, well, so honestly, I haven't heard a whole lot of detail. I'm a little confused just because that I got a phone call and then I had to, hop on a plane from New York to here. And so there hasn't been much opportunity for me to talk to anyone, but I know that I know he's got pneumonia, and I know they told me that he has trouble when he swallows, and that's why he got pneumonia. Um, that's about it. And of
It
course, I know.
sounds like it's, well, go ahead.
Oh, I was just gonna say, and of course, I know he has dementia.
Mhm. It sounds like this has been overwhelming. There's been a lot of information all at once, and you had to fly all the way here.
Yeah, it is kind of overwhelming. That's a good word for it. I do feel overwhelmed.
Yeah. I think it'd be understandable for anyone in this situation to feel overwhelmed. But in order for us to best help you as part of the team, I was wondering if there are things that you're most worried about that we could focus on today.
Well, let's see. It could be quite a list. I
Hmm.
guess yeah, I'm worried about how he looks so different. The last time I saw him was, God, it was almost 6 months ago, and I feel really bad about that. By the way, that's really hard that we live so far apart, and I don't get to see him often. But the place where he lives, they keep me up to date and stuff. But I was really shocked when I saw him this morning because he's so skinny, and he's so just. I'm not even certain he knew who I was. So yeah, just how much things have changed. I don't really understand if he can't swallow. I mean, how is he going to get nutrition? How will he gain weight? How can he get stronger again? Those kind of things. And I'm worried that he's here in the hospital for the second time, and he's not someone who would have appreciated that. So yeah, a bunch of stuff.
I hear that. I hear a lot of worries. I hear worries about how fast this has changed over the span of this year. I'm also hearing worries that he's in the hospital, and that doesn't sound like something he really would have wanted. And I
Yeah,
also hear that you're worried about how he's doing right now in terms of he's not eating as much.
right.
One of the things I wanted to ask a little bit more about is he's going through a tough time. What do you think are some of the areas of support or strength he has in his life?
Hmm, that's a neat question. He has been living in his current long-term care facility for about it's a little over 2 years now, I think. And oh, he so didn't want to go there. I mean, dragged kicking and screaming doesn't even cover it. But he's gradually become happy there. He's got friends there. He's got staff who've taken care of him, and that's his home now. So so I think that's kind of a um, I think that's important to him. He feels safe and cared for, so that's a source of support. Um, he has a strong faith. He's Lutheran, and he's always been really connected with his faith. So that's been important to him too. Um, there's me. I haven't done as good a job with that as I could have, but we are close. I love him. He knows I love him.
I can see how much you care for your dad. I
You
really
know,
hear.
I'm gonna do a timeout here, just for instructional purposes. Dr. Moore, how's this going for you?
I think we're working on the building the house part of it. So not yet into medical recommendations, but I'm trying to get a little bit more of the agenda setting to understand like what she's hoping out of it.
Absolutely. Does anybody want to just acknowledge anything that she's done specifically and all the information that she has gotten in a very short period of time? And some things that you see her doing that you would really want her to continue to do. Anybody want to speak up? Oh, naming emotions, being empathic, listening, not interrupting. Who is doing most of the talking in this conversation? Who's doing most of the talking? Paula is. And how is that happening? How is that happening? And that's because she is listening. She is listening and then acknowledging the emotion. What a great job. Um, Great rapport building, acknowledging of Paula's feelings. Lucia rocks. I agree. So you're doing a great job, and in a very few minutes, you have a tremendous amount of information, don't you? Paula does
Yeah.
have a lot of those feelings that we were thinking she might. You've learned he, probably doesn't want to be in the hospital here, and I'm gonna just encourage you to keep going. So go ahead. Thank you.
Thank you. So thank you for telling me about how he's been at the long-term care facility. It sounds like he's made a lot of friends. It sounds like he's been a really friendly person.
He is a very friendly person. I mean, he's very reserved. He's quiet. He's reserved. He doesn't, he's old school. He doesn't like talking about his feelings, but he is friendly, warm, kind. He's a very kind person. He's hard to get to know, I think people have found.
Mm. Thank you for telling me more about your dad. Something I'm curious about is even when he was reserved, have you and him ever talked about his wishes, like in terms of hospitalization? Earlier, you had mentioned um, he never really wanted to be in the hospital all that much.
Yeah, we haven't really had like a sit down formal conversation about that stuff because every time I tried, he just deflected it. But all his life, he's sort of tried to avoid going to doctors. I think the only time he's ever really been in the hospital before was to have his tonsils out when he was 14. Um, one of the things I worry about is how much he knows about what's going on because he would not have liked this. He would have hated it.
Mhm. I hear that you're worried about what are what are things that we could do that would be more in line with the care he would want.
Yeah. Yeah. I guess that's what I'm the most confused about is, what do we do now that he can't swallow safely? Somebody mentioned feeding him through a tube or something, and I'm just really kind of confused about all that.
Yes. Yeah, I hear that we're worried about what's next. And we're also worried about is the care that we're giving something that is in line with what he would want?
Yeah.
Is it all right if I share what my perspective is?
Yeah. Yeah. I'd like that.
Yeah. Your dad has been going through a tough time. He's been in the hospital a lot more than he's been ever in his life. We're in a different situation than we were a year ago. And as he's gotten sicker, he's been eating less, and we're thinking of what options we have to help him be comfortable and have care that he is okay with receiving. I hear how much you're thinking of what's best for him. I hear how considerate you are of your dad.
Thanks.
Based on what I heard that his ideals would be to not be in the hospital, maybe to be more with his friends. Did I get that right?
Yeah, ideally, yeah.
When I look at his history, as I'm seeing how often he's been in the hospital, um, the underlying cause of why he's here, the pneumonia, he got the pneumonia because he's been having more difficulty swallowing. And with the increased difficulty swallowing, that cause isn't reversible.
So when you say that cause isn't reversible, that means there's nothing we can do for it?
I hear that you're worried.
Yeah.
There are things that we can do to help your dad. And in terms of thinking about what's next, we can't reverse the way he's swallowing. And in terms of a feeding tube may be a way to give him nutrition, but that doesn't mean that the underlying cause of the pneumonia will go away. So he will still be at risk of getting pneumonia and could end up in the hospital again.
So he'll just keep on getting pneumonia and end up in the hospital.
This is hard news. I wish there was something better I could say,
Thanks.
but I hear that there are ways that we can keep him in line with the things he enjoyed. Like it sounds like he enjoyed being with his friends. He found a home at his long-term care facility. So we can brainstorm ways to maximize his time there.
Okay.
Something I forgot to ask earlier is, have you and your dad ever talked about the idea of comfort care or hospice? Have you heard of either of those?
Um, I've heard of hospice. I don't know very much about it. I mean, Dad's always been really impossible to talk to about about things like that. So no, we've never talked about it.
Okay. And the purpose of me going over this with you is to talk about options. We don't have to make a decision right now, but part of my job as being a doctor is to make sure you have all the information you need to make a decision that would be best in line with what your dad would want.
Thanks.
So, one of the things that I talked about earlier is something called hospice. So, hospice is an option of care where what we focus on is comfort. Having a pneumonia can be uncomfortable. Being in the hospital can be uncomfortable. We're away from what's familiar to us. We're away from our friends. What hospice is something where we can figure out what are ways we can help the patient be more comfortable in their own setting. So that means even at his long-term care facility. So that means if he becomes sick, we have options. He doesn't have to go to the hospital if he gets another pneumonia. We could also decide to stay at the long-term care facility and treat him there in terms of his comfort.
Oh, so okay. I guess I thought hospice was a place where you go, but
Mhm.
he can have that where he lives now. He wouldn't have to move.
Yeah, so that is a good question. So in terms of hospice, hospice is something where we can see if people are able to have it at home, or if their needs are greater, we can see if there's another facility or that could treat them for their symptoms if we're not able to have it at home.
Okay.
And usually the criteria for hospice is patients who have like frequent hospitalizations, they may have increasing weight loss, and they may have a severe dementia, and also have less than 6 months.
So you think that's true for him that he's got less than 6 months.
So, in terms of the timeline, when I say less than 6 months, this is just a prediction, a guess. There's a
Sure.
risk of it. It doesn't mean that it's definitely going to happen, but it is a possibility. And part of being a doctor is telling you about all of the options that we have. And this is something to consider when I wouldn't be surprised that he might, with the frequent hospitalizations, that he might pass away within the next 6 months.
Yeah, I mean, I guess I shouldn't be surprised. I mean, I always knew this was coming, but
It doesn't make it hurt any less. It's still painful. We're in a different place than we were a year ago.
yeah, I get it.
Yeah. So I know that I talked a lot today, and we talked a lot about different things. I wanted to ask what questions or any clarifying things you had for me.
Um, so what do we do about food? I mean, yeah, I mean, I guess I'm really unclear about that part still.
Yeah,
Because
thank you
he'll,
for asking. Oh, go
yeah,
ahead.
I was just gonna say, I mean, he's gonna die if we don't feed him, right? Well, he's gonna die anyway.
Hmm.
Yeah, I'm just confused.
Yeah, you're worried about what's next.
Yeah,
Yeah. In terms of what's next, is it all right if I make my recommendation?
yeah,
Yeah.
please.
So, based on how your dad has been in the hospital multiple times, and he has been having difficulty with eating, one of the things that we can do is still offer ways that we can still give him food for enjoyment, because we can still give him, he can still eat, but maybe the swallowing part of it, he might not be able to do safely, but that part will still be there. He will still have difficulties with swallowing, regardless of if we feed him or not.
I see.
And while there is some concern that he might be starving, usually as patients with dementia continue to age and continue to have progression of the dementia, the difficulty swallowing, there's also less appetite. And there's ways that we can help alleviate that discomfort. And some of the ways we can do, oh, I'm sorry, go ahead.
Oh, yeah, no, I want to hear about the ways we can do that. I just, that's what I want the most. I mean, I want him to be comfortable no matter what.
Yeah. It sounds like
Honestly.
comfort and avoiding the hospital are some of the common themes I've heard throughout our conversation.
Yeah, yeah. And I mean, he likes food. I mean, if he could somehow, still have ice cream. I mean, that's his favorite. Um, that would be comforting for him.
I think that would be a great plan. I think we shouldn't restrict his diet. I think we should continue to feed him whatever food still brings him joy. But in terms
Lucia,
of,
in the
oh,
interest
go ahead.
of time, so people have some time to react, I'm gonna go ahead and time us out. How did that go for you? How did you feel about that conversation?
I think it was interesting because I don't think I've done this in a virtual setting. So I know I might be missing on some cues a little bit.
You know, well, I just want to tell you, I absolutely think you did a tremendous job, and we can ask the audience. You know, who I really want to ask how she felt is Paula. Paula, can you come back on and tell us how that was for you, Dr. Kofer?
Well, so I feel like you brought me a tremendous distance in a very short period of time by asking those very specific questions in a really caring and empathic way. I felt like you cared about my dad. I felt like you cared about me. Um, I felt like you were being honest and straightforward with me. So, I feel like I went from confused and tired and guilty and a little pissed off to feeling some peace that we're going to have a plan that is going to be, good for my dad and what he would want. So yeah, I thought that was fabulous.
Thank you. Thank you. Has anybody been timing this? How long did this conversation take? When you think about having these conversations, do you think, oh no, it's going to take all afternoon to talk about that, And in a focused way and building the house and following Oscar nomination for Paula. Yes, I agree. She's had some practice, Barack. Yeah. Um, in little over 20 minutes, you have had the conversation, and look how Paula felt. And she's being honest with you, how you felt. Christine and I both do some acting in our facilitation role in the academy. We really get into it. And we can really feel it when people are really empathic and respond to our emotions and everything. So, in a very short period of time, a highly emotional conversation. And I think what she said is so key. You moved her, miles on the spectrum, if you will. Was confused, kind of didn't know what was going on. Somebody had asked, had considered or brought up a feeding tube. So I'm curious what the audience thinks about what you just saw demonstrated. Great job, especially a tough topic, says Hillary. Oscar nomination for Paula. Nancy says wonderful care, Dr. Moore. Anybody else? You can unmute and speak up.
I have the great pleasure of watching Dr. Amore do this on a regular basis as her fellowship director, and yes, kudos 100 times over. So, would you all say that her statement of "we're in a different place than we were 1 year ago" was her headline? Because I think the headline is really powerful and important from a practice perspective. Because oftentimes when we're giving our summary statement to patients and families, it's like, you know, 3 minutes long. But would you agree that was her headline statement? I just wanted to kind of highlight that as a really effective and important piece.
And a headline then followed by silence, because that person you're giving that headline to with serious news is going to go into a limbic hijacking state. And their emotional center is totally in control of their brain. Their prefrontal cortex is shut down. They're not going to remember the next thing you say unless you give time for that to clear. So, Carrie, great. Yeah, I had mentioned headlines earlier. Thank you for emphasizing it. We need to talk in headlines, not pages and not paragraphs. Headlines, 15 words or less.
Carol, I see your hand.
Yeah,
Thanks.
I was just gonna say, big Lucia fan here, so strong work as always. Thank you. I did like that headline too, and one of the things that it made me think about is how often the family members of people with advanced dementia don't understand the natural history of the disease, the normal clinical course. If you live long enough with dementia, this is what it looks like, right? So first of all, like all of us who are taking care of people upstream need to remember to coach around this eventuality. But also when we're in the acute setting like this, sometimes I find we do have to do a fair bit of teaching around that, this is part of the illness, the incurable progressive neurodegenerative disease illness that the person has. Because I think, for us, it's, of course, he can't swallow because he has dementia, but many, many people don't make that connection or understand the sort of irreversible and progressive nature of the disease.
Thank you. Thank you so much. And then I just, well, before I call on you, Brock, say that Karen is chiming in that, this we are in a new place is so critical as a caregiver and in several support groups, because it really helps to make decisions not based on how the person was, but the present reality with its challenges. And then, Brock, I want to call on you, but while I do, I just want to like do a shout out, and I feel like I need to share this beautiful slide because, so amazing. Sorry, both. Thank you, Dr. Christine Koper and Dr. Lucia Amore. Thank you both. Okay, I'm going to stop that, but I just wanted to do that. Thank you. Brock?
Yeah, I'm just going to say I also try to really take on the hunger issue sort of head on. And often people have had experience of sort of, caring for somebody dying of cancer and really pointing out how interestingly, as people are dying of cancer, they really stop feeling hungry. And so even though it's impossible for us to really know what somebody who's dying of dementia is really experiencing, we can pretty safely extrapolate from the experience of people dying of cancer to say that it's very, very unlikely that they are suffering from hunger. And I think that really helps to sort of alleviate a lot of the anxiety of the process.
Thank you.
Thank you so much. All right.
Well, Nancy, it looks like we're at time.
Yeah, in the service of time, I'm going to super quickly celebrate the Oscar performances and the compassion that we all witnessed today. And thank you, Mimi, as well, for your wisdom and your exceptional commitment to care and teaching and mentoring. And we're so fortunate to have you on our hub. Bring your cases
I have
forward.
one final slide with some resources.
Oh, absolutely.
Can I just put that up quickly?
Yep, absolutely. Thank you.
I was going to talk about what if Paula doesn't accept your recommendation. We don't really have time for that, but we do the same thing. We just go in and dance with her and go back and forth. Here's some resources. Linda Reed Seaman's book is a great resource for symptom management, communication resources. And then the last notation here, article that it really is hot on the press, if you will. Mr. Smith has no meal times. Hope Wetchkin, the medical director at Evergreen, and colleagues from around the country have written this article about minimal comfort feeding for patients with advanced dementia. It's a little different approach, and I just wanted to point that out. And with that, I will stop, and I want to say thank you so much for the participation. I loved it. And thank you for the opportunity to get people thinking along these lines. The answer to how to care for Mr. B is not in the physiology of dementia. It's in Mr. B's story.
Thank you. Thank you all. See you in 2 weeks. Thanks again.